So our first speaker in the session is Dr. Apurva Ayachit. Dr. Apurva is a consultant at Vitreoretinal Services, MM Joshi Eye Institute, Hubli, India. She has 26 index publications and 6 book chapters to her credit so far. She holds the position of assistant editor in the Indian Journal of Ophthalmology and is an active reviewer in international ophthalmology, clinical ophthalmology, ocular immunology, and inflammation. She leads the Young Ophthalmologist Society of India as academic in charge and has conducted several academic programs for young ophthalmologists in
Hello.
training, education, and practice in association with AIUS. Over to you, ma'am. There's a slight technical glitch in the program. She would be presenting as a third speaker. So I'll take up as the first presenter. I'm Dr. Kshitij Raizada. I'm practicing as a veterinary surgeon in India, and I shall deliberate on CNVM in Vogt-Koyanagi Harada syndrome. I have no financial interest to declare. Vogt-Koyanagi Harada disease is a bilateral granulomatous panuveitis with or without extraocular manifestations, which usually presents in females from their second to fifth decades and is more common amongst Asians and Hispanics. It's basically a T-mediated autoimmune reaction against melanocytes, melanin, and retinal pigment epithelium. The disease usually manifests in 4 stages: prodromal stage, uveitic stage, chronic stage, and the recurrent stage. The first stage, the prodromal stage, has constitutional symptoms like headaches, fever, orbital pain, nausea, dizziness, and light sensitivity, along with neurological and auditory manifestations, which usually last for 3 to 5 days. This is followed by the uveitic stage, in which the patient presents with blurred visual acuity, which may affect both the eyes, but the presentation may be asymmetric. There is anterior chamber inflammation, hyperemia, and edema of the optic disc with multiple serous retinal detachments. Over a period of few weeks to months, the disease moves into the chronic stage where we can see depigmentation of choroid, which characteristically is called as sunset glow fundus, along with perilimbal vitiligo, which goes by the name of Segura's sign. And there could be other manifestations like vitiligo, poliosis, and alopecia. The recurrent stage is constituted by acute exacerbations of anterior uveitis, along with long-term complications like cataract, glaucoma, choroidal neovascularization, which presents in 2 to 15% of all the VPH cases, subretinal fibrosis, choroidal atrophy, posterior synechiae, and optic atrophy. The diagnosis is usually clinical. There is granulomatous anterior segment inflammation. The fundus picture would show vitritis, hyperemic edematous optic disc, along with multiple pockets of exudative retinal detachment. The OCT will show neurosensory detachment, and there are some other features which I shall be soon discussing by means of an animated explainer video. The fluorescein angiogram would show hyperfluorescent spots in the early phase, followed by hyperfluorescent dots in the late phase, along with pooling of dye in the areas of retinal detachment, and it is characteristically called as starry sky appearance. The B scan would confirm the presence of a thickened retinochoroid sclerocomplex. The differentials include sympathetic ophthalmia, posterior scleritis, exudative RD due to malignant hypertension, intraocular lymphoma, and metastatic carcinoma. The management includes use of intravenous methylprednisolone, followed by oral and topical steroids and immunosuppressants. Now, dwelling upon the topic of this session, CNVM and Vogt-Koyanagi Harada disease, I shall walk you through a case by means of an animated explainer video. Please have the video.
Hello. Hope you all are doing well. This is Dr. Sharma. He is gonna share an intriguing case with you. So let's get going. A 36-year-old female presented to us with complaints of diminution of vision in both the eyes for past 1 day. Visual loss was preceded by headache for 2 to 3 days. Her best corrected vision in both the eyes was finger counting at 1 meter. Anterior segment in both the eyes had granulomatous inflammation. Her fundus picture looked like this. Bilateral optic disc hyperemia with blurry margins. Multiple pockets of subretinal fluid. And ILM folds over the posterior pole. OCT of the right eye showed undulating choroid. Thickened RPE. Serous retinal fluid. And ILM folds. OCT of the left eye had similar features along with subretinal septae and hyperreflective dots within the SRF because of fibrin. Our provisional diagnosis was Vogt-Koinagi-Harada disease and patient was started on intravenous methylprednisolone 1 gram for 3 days followed by oral steroids along with topical steroids. The patient responded very well and 1 week later her vision was 6/9 in both the eyes. The disc margins were now sharp. SRF pockets had resolved and the ILM folds had disappeared. OCT showed restoration of normal retinal architecture in the right eye while subtle irregularities in the ellipsoid zone were noted in the left eye. The patient was advised gradual tapering of oral prednisolone and she was started on azathioprine 50 mg TDS. She continued doing well and was 6/6 in both the eyes 2 months later. The patient was lost to follow up for the next 6 months. She reported 6 months later with diminution of vision in the left eye for past 15 days. She had discontinued azathioprine after taking it for some time, without the doctor's recommendation. Both eyes had developed sunset glow fundus, while the left eye showed subretinal hemorrhage and fluid at fovea and papillomacular bundle. While the right eye OCT was normal, the left eye OCT showed subretinal hyperreflective material and subretinal and intraretinal fluid. She had developed CNVM as a late complication of VKH and was given intravitreal ranibizumab for the same. She was followed up 1 month after the injection and showed resolving CNVM. Her vision had improved to 660 and OCT showed regressing SRAM along with resolved SRF and intraretinal fluid. Considering the good response after the first dose, patient was given a second dose of ranibizumab. Patient returned 2 months later with a BCVA of 624 parts. OCT showed regressing SRAM but re-emergence of SRF and IRF pockets. A third dose of ranibizumab was given. A month later after the third dose, patient is maintaining 6/6 in the right eye and 624 parts in the left eye. Left eye OCT showed resolved SRF and IRF. Patient did not want to get injected further for the time being. We are maintaining her on tapering dose of azathioprine, and we have advised her to not to miss the follow-up visits. CNVM in VKH disease has rare incidence. We would love to know how you would have liked to manage this case. Thank you for your kind attention. Goodbye.
I Spy.
Can I please have the next slide? Yeah. Now, regarding the pathogenesis of CNVM and VKH disease, there is an underlying chronic inflammation, and this leads to the destruction of the Brooks membrane, which leads to the release of angiogenic factors. The overall concentration of VEGF inside the eye increases, and this leads to the formation of choroidal neovascular membrane. The occurrence of peripapillary CNVM is very rare and is very rarely reported in the literature. And in case of our patient, the occurrence of peripapillary CNVM was confirmed by means of fundus fluorescein angiography, where we can see that there is early hyperfluorescence followed by late leakage. The diagnostic value of optical coherence tomography in the early diagnosis of macular complications in chronic VKH holds a lot of relevance, and therefore it is advisable that patients of VKH who are on a long-term follow-up, OCT must be done on each and every visit so as to pick up any macular complication which could develop in its nascent stages. The incidence of CNVM in VKH is rare. So far, there are no particular guidelines as to what should be the treatment in such cases. But the consensus so far worldwide is that we use intravitreal anti-VEGF injections for the treatment of CNVM along with steroids. Steroids decrease the vascular permeability by stabilizing the basement membrane of the CNVM, and they decrease cytokine production, which may prevent vascular budding. The use of steroids could be either oral or it could be intravitreal. So we need to use anti-VEGF injections along with corticosteroids because the ideal therapeutic goal is CNVM eradication along with inflammation reduction. The animated explainer video that we just watched is a production of our production house, which goes by the name of iSpy, and we regularly post videos for the purpose of enlightenment of ophthalmology postgraduates, fellows, and young practitioners on the website www.ispy.det.in and also on our Instagram, YouTube, and Facebook channels. That's all I've got to say. Thank you so much. Any questions from the panelists or the audience? All right. So now our next speaker would be Dr. Errol Chan. He shall be discussing about novel and emerging retinal therapeutics. Dr. Chan specializes in cataract surgery, retinal diseases, and uveitis. He is a consultant ophthalmologist with the Singapore Medical Group. He has been an investigator in multi-center clinical trials investigating novel retinal therapeutics. He has also authored more than 40 articles in the most read indexed ophthalmology publications and textbooks. Over to you, Dr. Chan.
Yeah, thanks very much. Thanks, Mice, again for the invitation to speak at this session. So today I'll be speaking on just focusing on some novel and emerging retinal therapeutics. So we all know there is a high burden of intravitreal injection treatment as well as monitoring associated with the management of these conditions. And therefore, there are just two very important aspects of disease management in 2022 and in the future, particularly in the role of treat and extend protocols, as well as the investigation of longer acting and sustained therapeutics for this. So in the context of this talk today, I'll be speaking about some of the novel agents in the retinal therapeutic space with the potential for broad. So I'll be speaking about novel agents in the retinal therapeutic space with the potential for future clinical use. So that would be faricimab for diabetic macular edema, as well as neovascular AMD, as well as the ranibizumab port delivery system for AMD. So we know that the real-world outcomes for DME and neovascular AMD treatment do differ quite a bit from the results from randomized control trials, particularly in the amount of vision gained. And this is all attributable to that in real-world settings, patients actually are not able to fulfill the number of injections due to compliance reasons, and therefore the resultant visual acuity gains are therefore less. So faricimab is a bispecific antibody that targets both the VEGF pathway as well as the Ang2 pathway. So the anti-VEGF agents that we are aware of, such as ranibizumab and aflibercept, these target the VEGF pathway. Faricimab has a FAB section which targets Ang2, and the other section which targets VEGF. So it therefore allows for a by dual inhibition of both disease pathways and potentially allowing greater durability in the treatment efficacy of these diseases. So in normal vascular states, Ang2 interacts together, Ang1 interacts together with the Tie2 on the endothelial cell walls, and this promotes vascular stability. However, in pathological conditions and retinal exudative states, this balance is dysregulated. Instead, Ang2 actually interacts with the Tie2 receptor and prevents downstream signaling. So this results in several pathological effects such as vascular instability, inflammation, vascular leakage, as well as neovascularization. We do know from laboratory studies that Ang2 levels are higher in retinal pathological conditions such as AMD, vein occlusions, and diabetic retinopathy, whereas Ang1 is produced and expressed at a constitutive level in all these conditions. So there are several clinical trials for faricimab that are currently in the pipeline. We do have the 2-year clinical data for the Yosemite and the Rhine studies for diabetic macular edema, and I'll touch on that in a little bit. But what we do also have is the 1-year data for faricimab in neovascular AMD, and so that will be the TENAYA and the LUCEN studies. So together, the results from these trials show the efficacy as well as the safety of faricimab for these conditions. So in the Rhine and Yosemite trials, this was a comparison of faricimab in 2 arms. Okay, the first arm was a 6 milligram dose Q8 weekly. And this was so this was dosed initially at every month for 6 doses, as you can see, and then thereafter 8 weekly. In the second faricimab arm, this was dosed at 4 injections, 1 given every month, and then the dosing of faricimab was adjusted based on certain clinical disease indicators. So this put every patient with what we call a PTI, a personalized treatment interval, which I'll go into in a bit. And these 2 arms were compared with the aflibercept, which was dosed as per labeling, every 8 weekly. So this was given in 5 initial monthly doses, followed by a Q8 weekly dose. So the personalized treatment interval was unique to every patient. So the treatment frequency of faricimab was altered depending on the VA, as well as the change in VA, as well as the change in central subfield thickness. So for instance, in the little chart that you see on the right side, if the CST has actually improved, the treatment interval was actually maintained, giving opportunity for the effect to be seen over further treatment courses. If, however, the CST was stable, then the treatment interval was either extended or maintained depending on the change in BCVA. Now, if the CST actually got worse, then the treatment interval was maintained or reduced either by 4 or 8 weeks, again depending on the change in BCVA. So the Yosemite and Rhine studies met the primary outcome, which was essentially taken at 1 year, showing that the VA gains were of faricimab on a PTI or 8 weekly interval was non-inferior to that of aflibercept at an 8 weekly interval. So this was the 2-year results, showing that the initial 1-year results were actually maintained over 2 years. So, but specifically, the data was very encouraging because it showed that more than 73% of patients could be maintained on an at least 12 weekly interval. And this finding was actually demonstrated across both trials. Of these, 50% of patients were able to be maintained on 16-week intervals. So these findings were also sustained at the 2-year mark. So another important finding from this study was that more patients were able to achieve freedom from any kind of fluid, so freedom from DME, when they were on any of the faricimab arms compared to on the aflibercept arm. What I've also not shown is that there's also data that shows that patients on faricimab were able to dry their maculas earlier than patients on aflibercept. So to summarize the findings of this study, so faricimab basically targets two distinct disease pathways, and these pathways actually promote vascular stability, and so it allows for a more durable treatment effect. Now, the 2-year results do show that the 1-year gains in vision were actually sustained over a longer period of time. And the improved anatomical outcomes of faricimab, okay, up to a treatment interval of 16 weeks, were actually favorable compared to aflibercept over the 8-week interval, particularly in terms of drying of the macula, so structural changes, and in terms of the absence of DME. What I've not given you detailed data on, but it's what I summarize here is that in terms of the safety effects, no red flags were raised. So faricimab was also investigated in the TENAYA and LUCENT trials. So these are phase 3 trials, similar to the RHINE and the YOSEMITE, except they are actually in neovascular AMD. There were two main arms of this study. So faricimab, which was as faricimab, and which was given up to a Q16-week interval, and aflibercept, which was at the Q8-week interval. So let me explain a little bit about the Q16-week interval for faricimab. So the initial dosing, as you see over here, was that 4 initial doses of faricimab were given. And then a key important point in the further management of these patients was at the 20 to 24-week mark. So if the patients were determined not to have any disease activity at week number 20, then as you can see, they would be given Q8 weekly faricimab treatments. Now, if the patients had developed disease at the week number 24, then they would be given, the interval would be slightly longer, and so that would be 12 weeks. Now, if the patients were dry at both visits and they were subsequently wet, were dry at both visits, then they would be treated on a 16-week interval. So this is basically a concept. So this is slightly different from a personalized treatment interval, where, as in DME, where the treatment interval was adjusted based on the structural and functional parameters of the preceding visit. So as you can see, this was the treatment plan in year 1. And the patients, so once they got onto an 8-weekly interval, they would continue on that 8-weekly interval, regardless of the structural or functional changes that occurred along the way. Now, in year 2 of the study, the protocol changes somewhat, and that's where the personalized treatment interval comes into play. So this diagram over here explains it a little bit more. As mentioned, patients who were dry at both weeks 20 and 24 were on 16 weeks. Patients who were dry at week 20 but wet on week 24 were at 12 weeks, and patients who were wet on week 20 but were put on 8-weekly intervals. So in terms of the primary outcome of this study, the data showed that there was a non-inferiority of faricimab up to a 16-week treatment interval versus aflibercept up Q8 weekly. So this is the forest plot. As you can see, the lower limit of the confidence interval for both the TENAYA and the LUCENT will way within the 4-letter non-inferiority limit imposed by the trial. So these are the VA gains, and as you can see, a very typical improvement in VA curves over here. A gain of about 5 to 6 letters over 1 year for both aflibercept as well as faricimab. So these are the 1-year results. In terms of the proportion of patients at specific treatment intervals, I would say more than 80% of patients were able to be be on at least 12 weekly treatment. So you remember initially they were given 4 monthly faricimab treatments, and then the decision was made to stratify them into 8 weekly, 12 or 16 according to the disease activity at that critical 20 to 24 week period. So quite a good number of them were actually you were able by the based on the protocol to be managed on at least 12 weekly interval. So we don't have the 2-year data at the moment. So these are just the 1-year data. And to summarize, we've seen that there is non-inferiority of both of these therapeutic agents. And of course, faricimab being dosed at a much longer treatment interval than aflibercept. There were no significant safety issues. In particular, if you remember for brolucizumab, that had certain, raised certain concerns about intraocular inflammation to the rates of about 5%, but that was not seen with faricimab. Okay, so moving on to the last retinal therapeutic option. So the port delivery system is a sustained release of ranibizumab, and currently, as I speak, we are actually engaged in an ongoing trial of this agent. It's a multi-center trial which I'm participating in Singapore. So this is essentially an implant that is surgically implanted into the pars plana. It's a refillable ocular implant. It contains a customized formulation of ranibizumab. And what it does, it allows for in-clinic refill and exchange procedures. So how it works is based on the principles of diffusion. Within the implant, there is a higher concentration of ranibizumab, and it will then diffuse down its concentration gradient into the vitreous cavity, allowing continuous drug delivery into the vitreous. Now, the Archway study was a study that reviewed a phase 3 study that looked at the efficacy of this implant. In terms of the inclusion criteria, okay, so these patients had neovascular AMD, and they were previously treated with at least 3 injections of intravitreal anti-VEGF agents in the preceding 6 months. And all these cases had to have shown a response to the anti-VEGF treatment in the form of whether it was a structural change or a functional change or both. So the study design was such. So patients there were 2 arms of this study. So the PDS with ranibizumab, 1 arm, and then the other arm was that of intravitreal ranibizumab dosed at the 4 weekly interval. So this was the best case scenario, and the trial really wanted to look at whether this implant was able to achieve the best comparable results as with the best possible ranibizumab treatment, which is actually monthly. So this was the study protocol. A little bit of a busy slide here, but we'll just explain it in a little bit. So as you can see, there was an implantation and initial field procedure at day 1, and then the in-clinic refill exchange procedures were taken every 6 weeks, so at weeks 24, week 48, and week 72. Now, there was an option given for supplemental intravitreal ranibizumab, not through the implant, but through the implant at weeks 16 and weeks 20. If any of the cases fulfilled any of the criteria that you see at the bottom, so again, structural and functional criteria, if there was worsening edema in terms of the central subfield thickness, or a reduction in BA based on number of letters. So, as you can see, the boxes with the blue outlines, so these were opportunities provided for in the protocol for investigators to give additional ranibizumab prior to the refill exchange procedure. Right, so this was the data. What they looked at in terms of the primary outcome was what was the change in vision compared to what was the vision at the start of the trial. So bear in mind that these patients all had neovascular AMD. They could be at different levels of vision. So what I was really looking at is whether the implant could sustain the same level of vision. So as you can see with the implant, as with the monthly injections, there was really no difference in terms of outcome, number of letters. So this was a good result. And it showed that PDS was actually equivalent to monthly treatment. So in terms of the numbers of additional supplemental injections throughout the trial period, you can see that for those with monthly injections, that works out, over over a 40-week period, that works out to roughly about 10 to 11 injections. Whereas in the PDS treatment arm, this was only limited to 2 injections. So this includes not only the initial fill and the refill exchange procedures, but also any supplemental treatment. So really a very small proportion of them actually required, supplemental treatments. So this was the safety data. The one thing that stands out is certainly that there are more complications compared with regular intravitreal treatment, particularly because this is an implant that's put in the eye. So certainly there are more instances of where there's this conjunctival blebs, which is surrounding the implant. And of course, there were cases whereby there was vitreous hemorrhage, cataract, and as well as some cases of conjunctival erosions and retractions. Now, one thing that does also stand out is the endophthalmitis cases. Certainly, this is one of the concerns that the company is considering. Now, some of these endophthalmitis is related to the conjunctival erosions that allowed for a portal of entry. But some of the endophthalmitis couldn't be explained by any of these other conjunctival complications. Having said that, the data from the study did show that patients who had endophthalmitis actually did recover vision, and as well as the patients with retinal detachment as well. They were operated on and they actually recovered vision. So this is an example of the conjunctival bleb that formed around the implant. As we all know, with trabeculectomy blebs, these are portal of entry for microbes on the surface of the eye to enter the eye. So to conclude, there are some promising retinal therapeutics that are on the horizon, potentially for clinical use. And it does allow us better treatment of patients with reduced treatment burden, which is important, particularly in patients in underserved countries. Thank you.
Questions from the audience? Thank you, Dr. Chan. That was really enlightening. Moving on to the next speaker, Dr. Apurva is a consultant at Vitreoretinal Services, MM Joshi Eye Institute, Hubli, India. Dr. Ayachit has 26 index publications, 6 book chapters to her credit so far. She holds a position of assistant editor in the Indian Journal of Ophthalmology and is an active reviewer in international ophthalmology, clinical ophthalmology, ocular immunology, and inflammation. She leads the Young Ophthalmologist Society in India as academic in charge and has conducted several academic programs for young ophthalmologists in training, education, and practice in association with AIUS. Over to you, ma'am.
Thank you so much for the kind introduction. I'm so excited to be here with Media Mice, although virtually, in this second expo. So my topic, which I have chosen, is instructive cases in diabetic retinopathy. And these are some of the cases that were very instructive to me, and I hope it is for the others as well. So let's look at the first case. Now, this is a case of right eye vitreous hemorrhage and left eye moderate non-proliferative diabetic retinopathy. Now, one would easily make a diagnosis of probably a vitreous hemorrhage due to proliferative diabetic retinopathy. But surprisingly, what it was during the vitrectomy, we found a horseshoe tear. So this is an important lesson that, before vitrectomy for PDRs, we tend to inject Avastin to control intraoperative bleeding. But when the bleed is due to a posterior vitreous detachment with a horseshoe tear that has caused an avulsed retinal vessel causing a vitreous hemorrhage, then an Avastin would be futile. So a very important history that we need to elicit in these patients who seem to have a vitreous hemorrhage in as a diabetic patient with a contralateral, maybe some degree of diabetic retinopathy. It's very important to ask for a history of floaters. And flashes, of course, flashes more importantly than floaters, because a flash would signify that the patient has some VR traction due to PVD. Now let's look at the second case. This was a 65-year-old gentleman. He was diagnosed as bilateral vitreous hemorrhage secondary to PDR and posted for vitrectomy for vitreous hemorrhage. Now, this is an intraoperative screen grab. You can see that there are these blood clots and these multiple hemorrhages all over in all the quadrants, and there are some dark red hemorrhages. And as we cleared the clots, we saw that there are some white-centered hemorrhages amongst the many at the posterior pole and in the mid-periphery. Now, this did not look like a typical PDR. So I did get a peripheral smear, and the patient turned out to have chronic myeloid leukemia. The WBC count was 50,000 and there were myeloblasts in the peripheral smear. Now, it's important to know that conditions like leukemia, which can cause rheological abnormalities, leukostasis and leukocytic adhesion to the walls, this can compound the hypoxia and the ischemia that is existing with the diabetic retinopathy itself. So this can cause compounded problems because of more intraoperative bleeding, more adherent clots due to dehemoglobinized blood, and so on. Now let's look at this next interesting case. Here we have this patient with the left eye vision of just counting finger close to face. Now, when we examined him, there was PDR in the right eye, and there was dense vitreous hemorrhage in the left eye with no view of the fundus details. This is the right eye OCT showing like a garden variety, some taut posterior hyaloid and some SRF. There's no reason to believe anything else apart from a PDR causing a vitreous hemorrhage. Now, this is a video of the B scan. You can see in the left eye where there was a dense vitreous hemorrhage, there is a PVD and possibly a tractional component to the retinal detachment. There seems to be a hyperechoic band that is coming from the disc. Now, let's look at what happened in the surgery. Now, as I was operating, I saw that there was a lot of traction and I saw this large clot. You can see that I'm shaving away at the clot, and this is what happens. There is a dehemoglobinized component right here, if you can notice, and it is so adherent to the retina that while I was trying to delaminate the clot, there is scares that I can do because the retina also is getting torn. So I shaved the clot to the extent possible. There was a tear around 1 disc diameter large, and I lasered it. You can see this is after getting rid of the entire clot. I was able to delaminate it. There is some hemorrhage at the end, but I injected silicone oil and the patient ended up doing okay. Now, why was this unique finding seen in this particular patient? This was again not like a typical PDR causing a vitreous hemorrhage. Why the dense clot? Why was it so adherent? We did review his investigations and found that this male patient had a hemoglobin of just 9. So there was a microcytic hypochromic anemia, and we investigated him further. and we saw that the HbA2 on electrophoresis was 6%, whereas it should be somewhere in the range of 2 to 3.3%. So an elevated band of HbA2 meant that he had a beta thalassemia trait, which again is the cause of his anemia, and the anemia compounding the hypoxic effects of a pre-existing diabetic retinopathy. So any vascular retinopathy due to multiple causes is bound to be a little more severe, and you can have intraoperative surprises in terms of more bleeding, more clots, and difficulties in managing these surgically. So this is the next case. We saw this gentleman with sudden diminished vision in the right eye since a week. The right eye was diagnosed as a PDR with vitreous hemorrhage, and the left eye was a lasered PDR. Now, he was posted for a vitrectomy in the right eye and fill-in PRP in the left eye. So now, the halfway through my presentation, I think most of you are pretty sure that it's not a straightforward vitreous hemorrhage. So here we go. So this you can see is a pretty okay lasered PDR. Like you can see there are enough laser marks everywhere already. So why did this patient bleed? This is precisely why. Now, there is a large retinal artery macroaneurysm with fibrosis at the summit of the aneurysm. Now, that fibrosis had to be delaminated, and there was this break here. So I lasered it. Right, I'll just play the video again. You can see this aneurysm. This was the intraoperative finding, a very fibrosed aneurysm at that. And this is the end result. Now, what happened to this patient after that was, this was the postoperative finding after a lavage. Now, this patient had a vitreous cavity hemorrhage. I had to do a lavage again and an FAE and oil, and this is under oil. He's doing pretty great. So retinal artery macroaneurysm was the cause of this massive vitreous hemorrhage and not PDR, because we saw that it was an adequately lasered PDR. Now, a RAM is because of uncontrolled hypertension. So like I said before, comorbidity management is extremely important in diabetics, because the comorbidities many times are the reason for why they develop complications, and it is not just due to advanced diabetic retinopathy. So next, let's look at this interesting case. This is a 60-year-old gentleman. He came with diminished vision in the left eye since 20 days. He was diabetic since 20 years with an HbA1c of 7.4, which is not too bad. There was history of cataract surgery in both eyes 3 months ago. And this was the worst eye, the left eye, which was 636 and N12. Now, let's look at the fundus examination. You can see that there is this round red structure, which could be a microaneurysm, but it's too large to be one. But anyway, so this could be like a bleed. This could be a microaneurysm. This could be a macroaneurysm. A retinal artery macroaneurysm is unlikely to be disconnected from any large arteriole. So it is in continuation with an arteriole more often than not. This doesn't seem to be like it. It is very, it's right at the posterior pole, right at the macula, perifoveally. And let's see what it is. So when we saw the OCT, we saw that there was some edema, there's large subretinal fluid. And there is this large cystic structure with a hyperreflective wall and an adjacent cystoid space. Now, this was the OCTA, and the OCTA reveals a small hyperreflective aneurysm sort of picture. Now, is this a microaneurysm? Is this a perifoveal exudative vascular anomalous complex? Is it a retinal capillary macroaneurysm, or is it a retinal artery macroaneurysm? If you'll just excuse me, just a minute. Yeah. So this is not a microaneurysm because it is too big to be one. It's not a RAM because it's not in continuity with a arteriole. It's size-wise, if you look at micro and macro, in between, it could be like something like a mini aneurysm. Yeah, so Okay. So now Spade et al. Have termed this as a retinal capillary macroaneurysm, and that's what we call it. And in these cases, these are known to have poor response to anti-VEGFs. So steroids and laser work better in such cases. Now, this is my last case. A 50-year-old lady with diminished vision in both eyes since 2 months. There was a history of fever since 2 months. I mean, not since. I mean, she did have a history of fever 2 months ago prior to her present symptoms of diminished vision. She was told by an ophthalmologist that she has a retinal problem and was advised oral steroids. Now, she has come to us with uncontrolled diabetes, and her tests for fever have shown to be normal. So her blood work was also pretty normal. Now, this was the dramatic picture we saw on the retina, and these are retinitis patches for the uninitiated. We see a lot of cases of epidemic retinitis in our part of the country, where a post fever and immune mediated retinitis develops about 4 to 6 weeks post the fever, and these are typical retinitis patches. You can see these plaques which are there. These are endovascular plaques, which are very telltale of post-fever retinitis, or what we call epidemic retinitis. That's why dengue, chikungunya, and Weil Felix tests were done, because these are the usual suspects for epidemic retinitis. Now, let's look at the OCT. You see the OCT. This is then OCT through the retinitis patch. There are hyperreflective edematous inner layers with a taut hyaloid and a lot of posterior vitreous cells. So she was uncontrolled diabetic. Like I said, the HbA1c was a little higher than desired, about 8.1. The fasting sugars was 196. We got a COVID antibody test, which was high. It was 9.51, considering that she had a fever. Now, doxycycline is something that we use empirically for epidemic retinitis, because many times these are rickettsial in origin. And we also started this patient on oral steroids. So 6 weeks later, this patient comes back to us. Please excuse me. Yeah, so this patient comes back to us with reduced retinitis patches, and she seems to have developed this big front of neovascularization with an adjacent subhyaloid hemorrhage. So you can see that this is a resolution of retinitis patches. However, with the resolution, she seems to have developed neovascularization. Now, this was the COVID era, and there was lockdown imposed in certain areas, and this patient could return only 2 months later. And here you can see this fibrosed membrane over the disc, and here you can see that all this has fibrosed pretty significantly, and there is this subhyaloid hemorrhage right here at the nasal side. And look at this fibrosing neovascularization. Now, this is the montage where you can see this nasal large clot or the subhyaloid hemorrhage, and this is a boat-shaped subhyaloid hemorrhage. Here also you see that. And since this looked like neovascular complication of, let's see, why is it a PDR or is it a neovascularization because of retinitis associated ischemia? Nevertheless, we went ahead and did a peripheral laser. Now, after that, we did a fluorescein angiography and looked at this intense, extensive leakage due to the NVE and NVD. So this is the time course. You see, this is at presentation. This is about 6 weeks later, and this is 2 months later. And now the patient has come back to us again after about 3 months. And you see there is vitreous hemorrhage and there's a hazy view of the fundus. And this was the picture in the right eye. Again, there is more hemorrhage and more neovascularization. So we filled in laser in the right eye and we planned an anti-VEGF followed by vitrectomy. Now, this is the final picture that we had 3 months later. Now, when the patient first came to us, it was just retinitis with not much diabetic retinopathy changes. But this patient developed what seemed like a PDR in 3 months. So we were compelled to make a diagnosis of a COVID associated vasculitis with extensive neovascularization. And we postulated that the COVID related retinitis compounded the already existing vascular retinopathy due to diabetic retinopathy. And this is manuscript currently under review, which has received a favorable review for double kind of vascular retinopathy due to the microangiopathic thrombotic complications of post-COVID retinitis and a diabetic retinopathy coexisting, causing an accelerated vascular retinopathy and neovascularization. So my take-home messages are that we need to keep an eye out for comorbidities in diabetic retinopathy, keep an eye out for anemia, leukemia, uncontrolled hypertension, like the cases I showed. We have to keep the differentials of hemorrhages in mind, and not everything is PDR associated. There may be other pathologies that are lurking, and we need to have like a global approach to every patient and not be blinded just by the diabetic status and the patient just having the possibility of diabetic retinopathy. There may be a lot of things going on. So these were my instructive cases of diabetic retinopathy. I hope all of you found it a little bit instructive. It was for me. Thank you for your patient listening. I'm happy to take any questions.
Thank you so much, ma'am, for such an intricately designed presentation. Any questions from the audience? All right, so now we will move over to the final talk, which shall be presented by Dr. Rajat Kapoor. He shall be discussing about neuro-ophthalmological emergencies. Having an experience of over 11 years, Dr. Kapoor conducts frequent hands-on and video-assisted skill transfer courses for upcoming eye surgeons in India and is an invited faculty at various national and international ophthalmology conferences. He has published book chapters with Springer Publications and over 15 research papers in peer-reviewed journals. Dr. Kapoor is an ex-fellow in pediatric neuro-ophthalmology and strabismus from LV Prasad Eye Institute and is a fellow of the International Council of Ophthalmology London and the Royal College of Surgeons Glasgow. Over to you, sir.
Thank you, Dr. Raizada, for this introduction, and I thank Media Mice for the invite as well. So I wanted to keep the certain situations which we come across in the OPD. So neuro-ophthalmology is somewhat a little bit trouble child for ophthalmology people. People are very comfortable with managing retina, cornea stuff, but when it comes to neuro-ophthalmology, just because we've never seen kind of variety of cases, so there's always a kind of hesitation of what to do when you face such situations. So this is what I want to come at, what to do when patient comes to you with a unilateral or bilateral disc edema, or they may have monocular or binocular vision loss, maybe associated diplopia or ptosis, and patients presenting after trauma, patients coming up with a complaint of painful proptosis, ophthalmoplegia, or headache. So these are the usual complaints which people might come with. So we'll discuss various case scenarios where patients come with these kind of issues. So patient comes with complaint of acute vision loss, and on examination, if the patient has disc edema. So I'll just show some variety of cases. This is a 41-year-old female who came with the complaint of diminution of vision in the right eye, and there was a painful eye movements. The patient had history of fever 5 weeks, 6 weeks ago, and she is not a known diabetic or a hypertensive. So visual acuity, as you can see in the right eye, was 20 by 200, and she had a disc edema, as you can see. When we go to the red 3 photos, as you can see, there is little bit of vasculature which you can see on the top of the disc. So it's a bit of a hyperemic disc edema. What we can conclude, and on doing the Humphreys field, we realize that the patient has involvement of the inferior and temporal visual fields in the right eye. So here we are thinking, okay, there is a disc edema, there is a relative afferent pupillary defect, and there is a loss of vision. So you are thinking something like inflammation of the optic nerve. So we would like to image this patient and we send them for a MRI orbit and brain. And we would want to look for lesions related to multiple sclerosis, which is very common in these patients. And on the MRI, this is the axial cuts where in the right eye, you can see there is a thickening of the optic nerve. And when you see the post contrast cuts, there is a lot of enhancement, which if you compare with the other eye, it looks more brighter and more intense. So that is when you say that possibly it is optic neuritis. We don't know for certain whether it is infectious or parainfectious. However, as per the optic neuritis treatment trial, we treat the patient with IV and oral steroids. The protocol says you have to give 1 gram per day for 3 days, followed by body weight tapering dose of oral steroids. So similarly, now this is the case slightly parallel to that. The patient is a 55-year-old male here, and he's a known diabetic and hypertensive, so he has a lot of vasculopathic risk factors which is going against him. And he came with a visual acuity loss in the left eye, which is around the same, like 20 by 200. But here, if you see, the disc edema is slightly different here as compared to what we saw before. Here, it looks like a little bit more pale. The disc has that whitish spots. There are not many blood vessels, which are seen over the disc. And if you see the other eye as well, the disc appears small, and the cup disc ratio is hardly like zero point 0.1. So it's a very small crowded disc, which is actually a disc at risk. So this patient we are suspecting, considering his risk factors, vasculopathic profile, you are thinking about ischemic aortic neuropathy, and on the visual fields we get inferior altitudinal field loss. So this patient, in some of the Western countries across Europe and US. So there's a spectrum or battery of investigations which are ordered when a patient presents with these kind of complaints. But in places like where we practice, maybe Southeast Asian countries, India, cost is a very important factor. So you can't really order so many investigations right at the outset. So that is how the clinical acumen comes in, where you can kind of differentiate right at the outset whether the patient requires a neuroimaging, whether the patient requires a lumbar puncture. So this is what we have to make a decision. So for this patient, since the diagnosis is pretty straightforward for us, since it's arthritic, non-arthritic ischemic neuropathy, we just check the patient's vasculopathic profile. And based on that, we treat the systemic profile. However, the patient's prognosis will not be as great. Optic neuritis patients do recover much better. So similarly, so this is what we are getting at, when to image and when not to image a certain patient. So when the patient comes of a younger age group, patient is having painful ophthalmoplegia or painful eye movements, and when the central visual acuity is involved more, that is the place where you're suspecting optic neuritis or retrobulbar optic neuritis, and that is where you have to definitely image the patient, because patient in the future may develop multiple sclerosis as well. Whereas when you have a older slightly patient who is old aged and who has a lot of other risk factors like diabetes, hypertension, dyslipidemia, and patient has a altitudinal field defect on the Humphreys, that is where you can kind of skip the imaging. Coming to the next case, now this patient came with the diminution of vision in both eyes, and his main complaint was actually a very severe throbbing kind of headache. And patient is a known smoker and alcoholic. You can see the visual acuity as such was 20 by 40 in both the eyes. The color vision was lost, and there is a disc edema in both eyes. Now, on further systemic examination, what we see here is that the patient's temporal arteries were quite prominent, as you can see in this picture. And so this is more of a arthritic ischemic neuropathy, and you have to feel for the pulsations of the temporal artery and palpate the artery, and these are the visual fields. So even though patient had a 20 by 40 vision in both eyes, but there is a severe involvement of the visual fields. That is why patient was very uncomfortable. And we sent the patient subsequently for a temporal artery biopsy, which is the confirmatory or the diagnostic test. And we treat the patient after, consultation with the physician about his systemic profile. And again, the treatment will be IV and oral steroids. Now, this is kind of flow chart where we kind of discuss about how to go about these patients because they kind of overlap with their symptoms and their presentation. So, patient who comes with monocular, sudden painful decreased vision, we ask for history of headache and jaw claudication if the patient is old. And then in terms of blood investigations, we see that the ESR or CRP is raised. So this kind of flow chart on the left side goes more towards a arthritic ischemic optic neuropathy. The patient who comes, on the other hand, with pain on eye movements and there is associated motility, you have to check the eye movement. So if the eye movements are full and whether the disc edema is present or absent, but you have to still go ahead and do a MRI brain and orbit and along with the gadolinium contrast. Whereas when the patient has ophthalmoplegia, that is when you are thinking more of retrobulbar causes. So you have to think about proptosis, you have to think about non-specific orbital inflammation, orbital apex syndrome, Tolosa-Hunt syndrome, or a catocavernous fistula. So these are the complaints related to when the patient comes to you with vision related problems, the sudden decrease in vision, painful, painless. So this is the spectrum. Now coming to a little different kind of spectrum where patient comes to you with say diminution of vision associated with trauma. So this is a straightforward history. The patient comes to you after like a road traffic accident. So this gentleman had a accident from a motorcycle. He was under the influence of alcohol and he met with an accident. He did not have a history of any bleeding from the ear or nose, which is a very important history you have to take. However, he lost his consciousness for about 30 minutes or so. And this is the fundus picture. As you can see, visual acuity in the right eye was counting fingers. That is probably because of the vitreous hemorrhage, which is there. We can't really see properly at the posterior pole. We don't know what is the status of the optic nerve, whether it's avulsed or what is the exact status. The pupil was fixed and mid-dilated. The other eye was normal. So this is the clinical picture which we had. So it's important to document these because some trauma cases who come with the accident, they can go into kind of a medical legal scenario. So it's important for us to maintain the proper documentation and fill the relevant forms, take proper images and take proper signatures from the patient and the attenders. So the patient had periocular kind of injuries as well. So in a trauma case, you are expecting more of, say, orbital fractures. So when you are thinking fractures, the MRI is not really a very useful investigation. You rather go for a CT orbits. And this is what the CT orbits show. So one important thing we have to look for, as you can see on the right side, you have to look along the course of the optic nerve, whether there is actually any bony impingement or any bone fragment which is broken off and is causing compression of the optic nerve. In this particular case, the optic nerve was almost clear through and through, and there was no optic nerve avulsion also, which you can see in the scan. However, on the coronal cuts, you can see there was a fracture of the base of the orbit and the medial wall. So again, management, you have the diagnosis and management will again, as per the typical course of IV steroids, 1 gram per day for 3 days, followed by oral steroids. And of course, visual prognosis is very, very variable. The earlier you start the steroids, usually the prognosis is better. So this is again like a flow chart where with respect to the patient's complaints and history and what kind of scenarios we encounter, we'll have to plan. So patient came with history of loss of vision post-trauma. So there are 3 most important factors here, whether the vision is patient is better than perception of light or the patient is no PL. So patient who has some light perception obviously has better kind of prognosis as compared to the others. Then in terms of duration, whether the accident happened within 8 hours, whether patient presented within 8 hours of the accident, whether he presented within 7 days or, after 7 days. So the earlier the patient presents to you, the earlier the treatment starts is always better. However, even after 7 days also, there is no harm in giving a trial for intravenous methylprednisolone. And on imaging, if there is any actually bony compression of the optic nerve, that has to be surgically corrected. Otherwise, even the steroids won't work. Now we come to patients who come to us with complaints of say diplopia or ptosis or proptosis. So I'll just discuss a couple of cases here. So patient came with the accident 10 days back, and he said that following this accident, there is a swelling and pain on the right side of the face, and my eyes become more prominent. So can you describe what are the questions, relevant questions we asked? So we asked the patient, can you describe the pain? Yes, patient has a severe throbbing pain. Is there any whooshing sound which you can feel in your ear? So he said, yes, I can feel some kind of whooshing sound. Is there any vision related complaint? So there is a blurring of vision. So the patient tells about all his complaints here. And on examination, so this is the picture, right? So you can see there is absolutely massive proptosis for the patient and the right eye. And there is a lot of conjunctival congestion and chemosis. There is lid edema. Pupil is almost mid-dilated and fixed. So this patient, when we this is the examination. So nothing which we can't see in the picture. There's absolutely massive proptosis there. Conjunctival chemosis, I mentioned, there's a grade 2 RAPD as well. And this is the 9-gaze picture of the patient where you can see the right eye is there's a large exotropia. and all the motility is restricted. Like you see the right eye, there is no abduction, there is no adduction, elevation, depression. So it's absolutely total ophthalmoplegia. And now that we image this patient, we see, can you see this dark black structure in the center photo where I've highlighted? That is a dilated superior ophthalmic vein. So this is like massively, usually this is a small black dot which is seen. And as you can see in this patient, the vein is dilated to almost a very big level. It's causing a big compressive effect in the globe posteriorly. So we make a diagnosis of a high flow CCF, and this patient has to be referred to a interventional neurologist or interventional radiologist for further management. Similarly, now this patient had a history of pain and eye becoming prominent like proptosis since last 2 months, and the patient didn't come for checkup thinking it will all get better on its own. But now that it's increased and there is also a certain redness in the eye. So now the patient has come to us and there is no history of trauma, no history of vision related problems. Patient is a hypertensive, but there's no other complaints as such. So this patient has left eye proptosis, and on the conjunctiva there are some chemosis, and as you can see the conjunctival vessels are very tortuous. These are typically called as corkscrew vessels, and there's also some ophthalmoplegia here as well, but not as severe as the previous case. The limitation of motility is quite minimal as compared to the last case, but there's severe congestion. So even in this patient, you can see on the left side, there is a dilated superior ophthalmic vein. But since this is a more chronic course, it happened over a period of say 2 months. On the contrary, the last case, it happened over a week. So this is a CCF, low flow CCF. So management would be again, so these patients are very prone to developing secondary glaucoma. So they have to be mentioned, they have to be managed using anti-glaucoma medications and again by a interventional surgeon. So these are the kind of situations which we encounter. It's a very important slide. So when, what do you see in imaging and what is the treatment protocol? So when we do the imaging, either using a CT brain or MRI brain, with or without contrast. So when the patient has history of trauma, again, the management will be more towards the IV and oral steroids. When the patient has some vascular aneurysms or, those kind of pathologies, it has to be, you have to do an angiography and then you have to manage using, help of an interventional surgeon. And when you are considering inflammatory or autoimmune conditions, that is where the blood profile comes into the picture, includes inflammatory markers, blood counts, ACE, ANA, chest X-ray. In India, TB is very common, so we routinely do a Mantoux. And then when patient has kind of meningeal signs like, pain on neck bending and vomiting and very symptomatic or high fever, that is when you have to really be serious and you have to go for a lumbar puncture CSF analysis. And these patients may require IV antibiotics. So approach, this is again now, this is again a flow chart of how do you should manage or approach a patient of acute painful proptosis associated with ophthalmoplegia without. So patient comes with history of trauma. If yes, then it can be one of these three things. If the patient has proptosis, so it can be either a high flow CCF, it can be a hematoma retrobulbar, or if it's related to any kind of infection, then even a cellulitis is possible. If the patient does not give history of trauma, but there is painful proptosis, then you have to ask about history of systemic diseases. If it's hypertensive, then there's probability of the patient having a low flow CCF. If patient is diabetic, you have to now, especially post-COVID times, you have to consider about fungal infection. And if the patient has thyroid, then you have to think about Graves' disease. So this is my final case. And again, the patient came with history of diplopia since 2 weeks. The vision is good, but the patient has a right face turn of 15 degree. There is a ptosis of the left eye and there is an anisocoria. I'll show you the 9-gaze picture for this patient. So as you can see, primary gaze, there is a left exotropia. And when you check the extraocular motility, the left eye abduction is full, as you can see in the left gaze. But all the other motility of the left eye is limited, whether it's up gaze, down gaze, or right gaze. And this patient we are suspecting, so since it is ptosis plus motility involvement, so we are thinking third nerve. And on the MRI with the contrast, we get inflammation of the third nerve. We can kind of, if I can point it out. Sorry, I can't point it out, but the third nerve is usually somewhere here we want to see in this area where along the cavernous sinus, as you go posterior to the chiasma. So along the cavernous sinus, you have to look for the inflammation. I think there's a small marking here. Sorry about that. That is the last slide. And how do we manage or investigate these cases? So when you are thinking about aneurysm, you have to go for angiography. Both MRA and CTA are both non-invasive and gold standard investigations. You have to look for systemic diseases. And if any infective pathology is suspected, then you have to go for a CSF analysis. So these are some of the spectrum of cases which we routinely encounter. And I thank you all for the attention. I will be happy to take any questions, please.
Thank you so much, sir. We surely had a lot to learn from your presentation. Well, that's a wrap. We hope you all found the session worth your precious time. Goodbye until we meet next time. And thank you, Media Minds, for organizing such a wonderful conference and the session. Thank you. Bye bye.